is regarded as the MGRS. And I think the dogma for MGRS is that we need to find a clone. I think with the C3 glomerulopathy in the MGRS, a lot of times we could not find a clone. Like you attributed, like the C3 factor, if we give immunosuppression and attack the B cells. So that's still a mystery. What is the clone? If we don't treat the clone, yes, the complement therapy might help to reduce the proteinuria. But if we don't eliminate the clone, then unlike the primary C3 glomerulopathy, the genetic associated, we might not get the same results, outcomes. I mean, my second question, again, is to nomenclature. I know that we reclassify all the PGM, the type 1, type 2, based on the etiology. This immune complex, MPGN, is a whole. So what is the immune complex? Are we still, like in the old days when we learn pathology, the MPGN pattern? So it could be endocarditis, it could be lupus, it could be a lot of different things. But this immune complex, MPGN, I think is referred to our original type 1, type 2. Does that include essential cryoglobulinemia, which a lot of the patient might have cryoglobulinemia totally negative, but we still call it immune complex MPGN, or this is like not really a wastebasket, but just a miscellaneous category. Yeah. It's not C3 glomerulopathy, it's not dense disease, it's not essential cryoglobulinemia. So what is this entity? Is this a miscellaneous entity?
Yeah, to take those in reverse, and I think immune complex MPGN is really still descriptive as a term, so this could easily be a secondary form of immune complex MPGN in liver disease or chronic infection. There's certainly speculation and good data from adults that chronic infections of a variety of sources can lead to that immune complex deposition and MPGN. So it is a little bit of a category rather than a distinct entity, but we still can find genetic and acquired drivers of disease in those patients. To come back to the first question, as far as the clone of MGRS in C3G, so as a pediatrician, I guess I have to plead a little bit of ignorance since that doesn't happen very much in the pediatric world. I will say that there have been reports that have identified binding affinity of the clonal antibody to complement proteins like factor H specifically. So there are monoclonal antibodies in that disease entity that have the complement dysregulating function. But beyond that, I think I'm out of my depth in talking about how to find a clone. So.
Yeah, I mean, it's a very good point, and frequently we will see restriction on a biopsy, so maybe kappa or lambda with C3G, and you can be sure as much as you can be that there is a clone, but you might never find it. I mean, we wouldn't actually call that C3G because we call that a monoclonal driven process, and because the treatments would be different. I mean, all the trials excluded these sorts of patients because, it's a very different disease process. And, although we think complement might be activated, still the drive is to get rid of the clone. And indeed, some aggressive hematologists, even if you can't find a clone with bone marrow, will still treat for a clone, even if they haven't been able to find it, if there's good evidence of restriction with C3G.
And actually in the US, I've kind of seen the opposite sometimes. There is a lot of pushback from hematology from treating the monoclonal gammopathy of uncertain significance unless it reaches that threshold of whatever % plasma cells. And I know we faced this, if you remember a long time ago, Dr. Brandon, a patient who had MGUS before transplant. They refused to treat that. We were just learning about C3G, got a kidney, had C3G in the kidney, then got treated. So I think they're coming around to it, but, I think there is still some pushback.
I mean, it really depends on your hematologist and how engaged they are on that. We have the same issue.
Yeah. Yeah. All right. Any other questions? All right. If not, we'll move on to our third talk. Alex, is there anything from our virtual audience? Okay. So our third talk today is by Dr. Carla Nestor. She's going to be talking about the drug trials, the newcomers that are shaping the future of C3G. Dr. Nestor is the Jean Robillard Professor of Internal Medicine and Pediatrics and Division Director of Pediatric Nephrology at University of Iowa. She's internal medicine and pediatric trained, NIH funded, tenured faculty member with a translational research program focusing on rare complement-mediated kidney diseases, including aHUS and C3G. She is also the primary investigator for the University of Iowa C3G's natural history study, which includes one of the largest prospective cohorts of patients with C3G. Dr. Nestor is a clinical trialist, and her MedPeds clinical practice is a hub for bringing in the new generation of anti-complement therapies. Dr. Nestor.
Thank you. And I'm going to probably go fairly fast this evening because obviously a lot of the people in the room actually know a lot about these trials already. But I do want to make sure that the data is available to us once we get to the cases so that we can go back to them as we think about them. My disclosures, obviously as required by my university to share with you, but also be important for you to understand what my biases might be. Very quickly, we'll go through the factor B blockade in C3G, and then we'll go through C3, C3b blockade in C3G and immune complex MPGN. But before we go that direction, let's very quickly, still today, if you were to follow guidelines, you would be following the Chapter 8 KDIGO guidelines that were actually published in 21. They're not based on trial data. We've discussed this in more than one venue here. They are obviously retrospective, and they were designed because of a generic approach, essentially, to a proliferative glomerulonephritis. Without better evidence, it seemed like a reasonable direction to go. And this is kind of what it looks like. Of course, these are fairly obvious things: optimal blood pressure, optimal weight. You don't want the patient to have all of those healthy lifestyle things. But then when you move forward to treatment, you want to make sure that, in fact, it was placed in KDIGO specifically to make sure you rule out that monoclonal, because what's been said already is this concept that if a monoclonal is present, the true treatment first-line therapy should be towards that monoclonal or towards that clone, and then you'll think about what needs to happen next. But notice that the guidelines were written for 1 gram, and I will be very honest, we didn't know how much we should actually place there. There was discussion about children, we should do it at 0.5, whether we should do it at 1.5 in adults. Even, I believe, in the controversies, it might have even have said 2. There were lots of different discussions actually about what the cutoff point was. Really, I'm discussing this in great detail because at the very least, you should have done your biopsy by the time it's 1 gram. Maybe I'll start there because you're not going to know whether you need to treat unless you've actually done the biopsy, right? So that's my public service announcement about doing biopsies early. And then finally, the initial treatment was mycophenolate mofetil and steroids. And of course, we didn't prescribe the steroids in peds. We tend to do it much shorter. In the adults, they might do as many as 16 weeks, even up to a year, for instance. But definitely your patients appreciate the shorter steroids. Then we said you could consider eculizumab just because of some relatively small cohort studies, and I'll share at least one of them. And then, in fact, consider a clinical trial, which actually was perfect because you all will know that the phase 2 for Iptacopan began roughly 2019 going into 2020. So it was important that we were actually encouraging patients into clinical trial at that time. So what are you doing about chronic kidney disease? Well, these are straightforward. You do this in all your other chronic kidney disease patients. You're going to use blood pressure control, and that's generally ACEs, ARBs, or renin blockade in some fashion. But you're also going to worry about weight control to reduce the stress on the gloms. You're going to do lipid control. And of course, you're going to think about all these new agents that are being approved for CKD. So SGLT2 inhibitors, you're going to think about AT1, ETA1, or ETA inhibitors, et cetera, et cetera. Yes, you are definitely going to think about these as an option, but please keep in mind that CKD approaches, they were not present for us when we created the last set of CKD or of KDIGO guidelines, but even today, they are not meant to replace targeted therapy, and that's the thing that's going to be most important as we move forward. Now, I don't know exactly what the new KDIGO guidelines will look like, but just keep in mind, in general, these agents were not meant to replace targeted therapy. So then let's very quickly talk about why did we choose urine protein? Well, the easy answer might be because the regulatory agencies were going to allow an indication based on whether we could actually reduce urine protein. But I like to use the UK data actually to support this. In fact, this is an example of whether you had greater than 0.88 grams per gram of urine protein versus less than 0.88 grams per gram. So you can think about that at that 1 gram roughly. So if you were in the pink box, those were the group that had more than a gram of urine protein approximately. And notice what their Kaplan-Meier looks like. This is a group of patients that based on that urine protein, their renal survival was actually not great. So that is one of the reasons why urine protein ends up being important to us. But I also like this presentation from the RADAR group in that they've also shared with us based on their data what the hazard ratio is for reaching kidney failure based on what you're able to do as far as proteinuria reduction, which fits beautifully into our clinical trials, right? If we can reduce the proteinuria, we reduce the risk for developing kidney failure. So these actually occurred after the trials were already started, but this is important reasons, if you will, to actually be able to use proteinuria as a retarget. And then, of course, quick, brief, you guys know C3G. It's the disease that we still quote 50% of patients will go to end stage by 10 years of diagnosis. The median age of the patient that's diagnosed is a 16-year-old in our database at the University of Iowa and also in RADAR. So that's a patient that's going to potentially go to end stage at 26, right? Or before 26 years of age. And in fact, the RADAR data would have supported that 85 or 63% of their C3Gs and 70% of their IC-MPGN patients reached kidney failure in a median time of 9.7 years. So that's consistent with what we've been quoting for a long time. And then, of course, they very briefly got into the allograft loss issue, which, of course, is going to be very important to some of you. So here's my version of what's the efficacy of the standard of care, and that's the mycophenolate mofetil and steroids. And I produced this figure a long time ago, actually, because it actually went into our document for KDIGO. And you can see that these 6 cohorts, they're ranging from size from 14 patients up to 42 patients. And red particularly was the flat out non-responder group, right? The green was the responder group. The yellow was either response in urine protein or response in GFR, or partial response, if you will. And then, in fact, the blue were those that not only were non-responders with respect to proteinuria GFR stabilization, but also flat out went to end stage. So not very successful if you're thinking about either saving the urine protein or saving the GFR. So what about eculizumab? And this actually is the adult version of this particular paper. There were actually 26 patients. And I know it's very small type, but the top row is what happened to the creatinine. For instance, in that first one, it went from 5 to a 1.5 creatinine, or what happened to the urine protein is just below that. So you can see in yellow are those that actually had both a GFR and a protein response, and in red is no response at all. So just so that you won't have to read that, I'm going to summarize it and say 6 of 26 patients total. Again, this is the adult group. There were another 13 pediatric patients, and 6 of 26 had complete remission. 6 of 26 had partial remission, and it didn't make a difference whether it was MAC high or not. And I bring that up only because it has been published that you needed an elevated C5b-9 in order to pull the trigger on eculizumab, and it's just not true. If you want to use eculizumab, you use eculizumab. It doesn't have anything to do with whether the C5b-9 is elevated or not. In fact, one of my index patients was a transplant patient who had completely normal C5b-9, and he actually responded beautifully to eculizumab. What about allograft recurrence? And I bring this up only because, these patients are already on mycophenolate and CNI, and it's a decent size meta-analysis, and, you can argue about whether this is useful data to you or not, but 122 patients, 33% of them lost their allograft after you even applied the eculizumab. 42% lost their allograft after plasma exchange, and 81% after rituximab. And I know the question was asked earlier, if they're nephritic factor positive, or why aren't we using Ritux or plasma exchange, for instance? It just hasn't got a good track record for either one of these things doing anything about being able to stabilize patients who either have native kidney disease or, in this case, actually have transplant kidneys. So let's get to the factor B inhibitor, iptacopan, or Fabhalta data very quickly. So it's an oral 200 milligram POBID. I mention every time I stand up here that we started using the agent back in 2019 in the phase 2, mostly in transplant at that time for us, but we also had to add some native kidney disease patients in there too. But this is the pathway. This is what you're blocking if you're using a factor B inhibitor. And the really important piece to notice there is that you have the ability to block both of the important central enzymes, so both of the convertase, the C3 and the C5 convertase. This was 18-year-old native kidney disease. Phase 2 included the transplant, already mentioned, and adolescent C3G phase 3 is ongoing, as is the adolescent and adult IC-MPGN. And again, I'm not speaking a ton about IC-MPGN in this particular setting, though of course I'll bring it back up again when we get to pegcetacoplan. And again, the sort of bench to bedside thing, I want to mention the fact that in fact, if you use a C3GN mouse model and you knock out factor B, so you essentially apply some iptacopan on this mouse, they do actually get amelioration of their disease. So it was a good background noise for us to have prior to actually thinking about using a drug such as iptacopan. Very quickly, there's the key inclusion, key exclusion. Not any surprises there for you, but I'll go through just a few. I already said this was 18-year-olds and up. Biopsy confirmed C3G. Of course, that's a requirement for any study in C3G. Urine protein at least 1 gram. There had to be evidence of complement dysregulation or a low complement level. For instance, the serum C3 needed to be lower than, I believe it was 10 or 15% of normal. So that's where that 77 comes from. But also notice that they're going to be on ACE, ARB, they can be on mycophenolate. They could have been also on steroids, but really only down to the 7.5 milligrams, et cetera. And then, of course, makes sense. They couldn't have had any risk factors for encapsulated organisms. The exclusion, the only one I'm going to really pull up for you is that they couldn't have had more than 50% scarring. Just you can read the rest there, or you can even pull it up very quickly yourself, because again, we do want to get the ability to be able to run these cases. Here's the baseline population. 2 things are pulled out for you. Of the 38 iptacopan patients, they did tend to have a slightly higher urine protein to creatinine ratio, and they had a slightly lower GFR, you can see, as compared to the placebo. But you can see the breakdown there, C3GN versus DDD, et cetera. Number of years with biopsy are fairly close, if you will. So not a lot of other significant differences between the placebo and the iptacopan group. So we do have the fortunate opportunity to actually have this as published data for us. It was actually placed in the Lancet. It got published officially, I think, October 11th. So this is really pretty fresh off the press, if you will. And this data included both the 6-month data and the 12-month data. So I'm going to match PEG in the same way so that you can sort of try to, in your head, compare these two. But at 6 months, there was a relative reduction of urine protein by UPCR of 37.8% if you compared the iptacopan treated with the placebo treated. And that drop happened fairly quickly. You can see on the lower figure, perhaps, that you can see that it was already heading down fairly quickly. At 1 year, so taking it forward, iptacopan-treated patients, they persistently had a nice reduction in their urine protein. And in fact, it was at 40% reduction in urine protein by 1 year. And the placebo group now, who's been switched from placebo, I didn't focus on that too much, but it was 26 weeks of placebo control. Then everybody went into open label, and so everybody then was treated with iptacopan. And in fact, the group that was placebo has now got a 31% reduction in their urine protein. So both trials used a composite endpoint, and what that really refers to is at least a 50% reduction in urine protein and a stabilization of GFR, which really essentially meant no more than a 15 milliliter per minute change in the GFR. And I'll just focus in on I didn't circle it for you, but perhaps you can see that won't work. But you can see for the composite renal endpoint that 30% of the iptacopan treated patients actually achieved the composite renal endpoint as opposed to 6% of the placebo. Then if you skip over to, I think what's your far right, 45% at 1 year of the iptacopan treated patients now have their composite renal endpoint, and 24% of the placebo group do. So that 6% was actually able to gain some ground at the 12-month mark. So how about the renal filtering function? This is the primary outcome of this study, I think, as I already mentioned, was in fact proteinuria. This is a subsequent endpoint that we're going to look at, and I think it's actually kind of appealing here, so it's worth sharing, obviously. At 6 months, the estimated glomerular filtration for the iptacopan treated group was positive 1.3. I shared with you what the radar data said. That group lost up to 9.7 GFR points, et cetera. We've always quoted that patients will lose about 10 a year. That's why we get to end stage in 10 years, that 10, 10, 10, et cetera. So a gain of GFR points obviously is going to be quite appealing to most of us in the glomerular disease world. And then, of course, the placebo group lost in 6 months 0.86. Now, this group actually collected an interesting few pieces of data here. In fact, that they went back and collected the creatinine prior to induction or prior to bringing randomization and bringing into the trial to try to figure out with, these patients could be more or less their own, a kind of their own control, if you will. And in fact, annualized eGFR prior to getting exposed to iptacopan was 7.57. So again, you're hearkening pretty close to what we've quoted and what in fact you've seen in the radar data. So that's satisfying that you're getting something that's consistent, as opposed to the group so it was plus 1.44 after treatment with iptacopan. So nice slope downwards there that you see is now starting to go back up again. And that is something that as a global group of individuals, this very serious disease, if you will, we have not seen before, from a global group standpoint, so that the estimated GFR gain was actually 9 in a year. Exploratory endpoint was C3 deposition. This is appealing to me because, of course, the animal models would suggest if you're actually doing what you think you're doing or doing what we want you to be doing, you should get some loss of C3 deposition. That's been shown in mouse models, rat models, et cetera. Anyway, the bottom line is that there was, in fact, they had some calculations, which you can go back to the manuscript and actually look at that, or even some of our earlier presentations at some of these congresses and figure that out. But it was basically a minus 1.875 in the adjusted mean difference for the iptacopan group versus the placebo. So we did see C3 deposition changes here. And then last but not least, you would like to know that you actually are affecting the biomarkers and you're affecting them in the direction you think you should be affecting them. So if you are blocking the breakdown of C3 by altering the activity, if you will, of those convertases, then in fact your C3 should go up. And you can see actually quite nicely that the C3 did in fact go up very quickly in the iptacopan treated group. It did not in the placebo group, because that's what happens to C3G patients usually, as opposed to PIGN patients. But notice as soon as they get placed on iptacopan, then that placebo group goes up. And the same story is there for soluble C5b through 9. So it was satisfying for us as a group of PIs to actually see that those actually moved in the direction we expected they would move. Then, of course, the safety data is there, and I'm happy to come back to this. I don't want to shortchange the safety data except for to summarize that basically, unlike what we might have thought in 2011 or so when we first started experimenting, if you will, with complement inhibitors, it turns out that these agents are going to be absolutely tolerable in terms of what we can do for our patients, I think. So keep that in mind. So here's the list of conclusions. Pretty much everything I said to you already. So basically, very nice trial, very successful, clear. I have many patients either in phase 2, phase 3, or compassionately, and many of them are doing very well. Okay, so let's now move also very quickly to the C3b inhibitor called pegcetacoplan, or Empaveli. Here's where you are on the chart, and you're seeing a theme here, right? We had suspected that if you target those central enzymes, you're going to have some successes in the C3G group. And sure enough, at least with iptacopan to this point now, you've seen that, and you're going to see what I'm going to share with you on the pegcetacoplan group. So this is subcutaneous infusion. It is self self-administered at home, either Monday, Thursday, Tuesday, Saturday, that sort of thing. It's a 1080 milligram twice per weekly. Now it's being done with this fancy little device. It was trialed, I think, or it was being used in PNH. I personally don't have any patients on the little device yet, but it's coming. FDA approved for, the study was created for the greater than 12-year-old native and or transplant kidney, C3G and or IC-MPGN. And I actually forgot to mention that that obviously Iptacopan has now been approved by the FDA. We don't know when it will be approved by other regulatory agencies, but we assume that it will happen soon-ish in some of the other countries. Again, my hope to sort of bring you back to the bench a little bit. In fact, we talked about this at a lecture I did earlier today, where in a rat model, if you consume all of its C3, the analogy I'm making is if you bind it and make the C3 not allowed to be cleaved, if you will, in fact, they can clear the basement membrane, or they can clear the C3C off their biopsy in 24 hours. So we should expect when you do this trial that you see some clearing of C3 off of the basement membranes. Okay, very quickly, here's the inclusion, exclusion, same thing pretty much as you were seeing before in terms of the exclusion of greater than 50% global sclerosis was not allowed. The difference here, of course, is we've got adolescents in the group, we've got transplant patients in the group, and we have IC-MPGN patients here. Not a lot else was changed except for one thing I will make a note of. They did also require the 1 gram of urine protein, not only in their native kidney disease patients, but also in their transplants. So that was what would be a little bit different here. The rest of it is pretty much the same. They did allow background therapy. Slightly higher degree of steroids, I believe, in this study were allowed. I think it went up to 10 instead of 7.5. Don't quote me on that. But otherwise, a lot of the inclusion exclusions were fairly much the same. Again, the primary endpoint was urine protein because, of course, I'm imagining that these sponsors knew what the FDA was going to be looking for, and because the trial was only 6 months, so you're not going to plan a whole lot of changes in your GFR, or rather, you're not going to plan on a ton of patients ending up on dialysis in that 6 months, so that would not have been an ideal endpoint. And so you can see the primary endpoints, proteinuria, but then you can see very similar key secondary endpoints, which include the composite, include also 50% reduction in urine protein, et cetera, but then also the decreased C3 staining. So you can see all of that listed there. Here is the basic baseline characteristics, and I'll only point out to you that, again, fairly close across the board, if you will. Importantly, you might want to focus in on that there were 12 and 16 immune complex MPGN patients there. The DDD versus C3GN patients were fairly balanced. And just to be complete, it was only 9 transplant patients, but 9 transplant patients is better than 0 transplant patients. So baseline characteristics. Okay, so here's a real down and dirty what happened to the urine protein. And you can see, depending on, or it didn't make any difference what your cohort was, whether adolescent, adult, C3G, immune complex MPGN, no transplant, post-transplant, et cetera, you had a very nice reduction in the urine protein across the board. So, and in fact, there's your numbers for that. And this is relative, obviously, to the proteinuria at week 26 compared to the placebo, because again, this was a very similar study, 26-week worth of placebo controlled, then everybody moves into open label. So here's what the proteinuria reduction looks like, and a little bit of I told you I was going to present to you 52-week data because that's what I presented to you in the Iptacopan. And in fact, you can see that initially the placebo group doesn't have a lot going on, obviously. In the Pegcetacoplan group, you've got a very nice reduction and then stabilization. And very importantly, out to 52 weeks, you have a nice stabilization of the urine protein to minus 67.2% compared to baseline. And those that were in the placebo group, once they began on their Pegcetacoplan, also got a very nice reduction in urine protein that appears, at least up to this point of the 52 weeks, to be fairly stable. How about the renal function? 52-week data suggests that it's for the placebo to Pegcetacoplan minus 4.7 milliliters per minute from baseline, as opposed to the Pegcetacoplan to Pegcetacoplan group is minus 3.7. So again, definitely not reaching our minus 9.7 or minus 10 that we were talking about before as these patients in their more natural state, if you will. And here is obviously some of the more exciting data too, because of what was suggested by the rat model. They did this a little bit differently than the Iptacopan group. There wasn't basically a formula that went into this. This was just, clear just assessment of 3+ versus not 3+, that sort of thing. And in fact, they saw 71.4% of their patients, these were adults, by the way, the adolescents were not rebiopsied at 26 weeks. So it's the adults at 26 weeks. 71.4% pegcetacoplan treated patients achieved zero intensity, like that rat model, staining on their biopsy. And in fact, very similar to the other study, we have a nicely safe study. Now, COVID-19, we could discuss that more. When I talk to my ID people, they don't think that complement should be a requirement for someone surviving a COVID-19 infection. In fact, many of you know during the bulk of a COVID-19 infection, they were using complement inhibitors as much as they could in the ICUs. So in fact, I don't think that that's related. Thank you. That was fast, so please ask questions.
Thank you, Carla. Thank you. That was fabulous. It's very exciting. I have a question.
Carla, I have a bunch of questions here. But first of all, it looked in the Iptacopan. I like taco in the middle. So, so the 50% reduction in proteinuria, the mean was 3.3 grams. That means they ended up with 1.7 grams of protein. That's not a cure. That's a pretty good treatment compared to nothing that we've had, but still, that's a lot of proteinuria, right?
Good. Yes, it's still a proteinuria, but what I would throw back at you is going from 3.3 to 1.8 potentially takes the patient out of nephrotic syndrome. So,
Yeah, but what if they're 10 grams and they go to 5?
yes. Okay. Now I would argue that that's not as useful for me, but
Yeah.
going from 3.3 down to 1.8 is actually not all bad as far as I'm concerned. Number one. Number two, because the nephrotic syndrome obviously bothers the patients, but also it changes their nutritional status. I mean, it does a lot of different things. So
I get that, but it seems to me something else is going on.
well, because the next point I was going to make is that I haven't seen the data to know how much scarring was left on that 1.8 gram biopsy.
That's my next question. So the Pegcetacoplan, they've got to get a better name. The histology was great. 0 is a powerful number or non-number. So 3+ to 0, that's great. Did they have histology data in the Iptacopan?
I have not
trials.
actually seen that data. I'm sure they do have the data, and I'm sure maybe David knows.
Because when clinicians come to this, it's going to be self-administered, something you stick on your stomach to take a pill twice a day. And if it's all things being equal, people like pills.
Yes, so for the Iptacopan data, the analysis was slightly different, and I'm not necessarily sure I can explain. They came up with a scoring system which did show a reduction in C3. It didn't seem to go down to 0. The slight problem is the results are not necessarily comparable because different antibodies were used, despite the fact that it was the same company that did it. And I can't really tell you whether that has made a difference in the outcomes. I mean, they were very different populations in the study. So, I mean, the Iptacopan only was C3G, Pegcetacoplan was both. Iptacopan, you had to have low C3. With Pegcetacoplan, you didn't.
And I think he was also asking about the light, for instance, to know how much scarring. Do we know that? Do we have any idea about that?
Yeah, we don't know that.
Yeah. And then you probably mentioned it, but it went fast. What was the starting protein in the Pegcetacoplan groups?
Yeah, I can pull that up.
Yeah. Just because it was 3.3 and it just went
It
fast.
was comparable between the two. I think it was 3.5 and 4. Let me see.
It's not terribly off. You can see.
Okay.
4 and 3.3.
Okay,
Yeah.
okay, fine, yeah, okay, that's it, thanks.
My voice is not enough.
It's okay.
So I, again, do mainly transplants, okay?